Well, good afternoon, everyone, and I hope you all had a good lunch. Now that everybody's starting to get that post-lunch drowsiness, we've been asked to help wake you up, and I think we'll be able to do that. Along the themes of this morning's presentations about borderline resectable cancer, we've put together a How I Do It session, which is meant to be as much a learning experience as it is a rigorous debate. This will be the schedule for this afternoon's session, and we do plan to make it very audience interactive. I'll do a brief introduction of our speakers and the topics, and Jason Fleming, my friend and colleague and fellow moderator from MD Anderson, has crafted some very interesting cases for discussion for our panelists. And along those lines, our panelists include, for the first case, Dr. Charles Vollmer, Chief of the Pancreatic Surgery Service and General Surgery at the University of Pennsylvania. And Chuck will argue a surgery-first approach for a patient with borderline pancreatic cancer. His opponent in debate will be Dr. Sai Ahmed from the University of Cincinnati. Dr. Ahmed is well known for his work with neoadjuvant therapy and will argue a pre-op or neoadjuvant approach for a patient with borderline resectable cancer. Following their presentations, we'll have a good 15 minutes of audience participation and interaction. And gentlemen, please ladies and gentlemen, please feel free to step to the microphones and have at these two young fellas. Then we'll follow the second case with a different tact on borderline resectable pancreatic cancer, and a patient who has borderline pancreatic cancer, maybe not by radiographic criteria, but by age and performance status. And our two debaters for that session will be Dr. Charles Yo, Chairman of Surgery at Thomas Jefferson in Philadelphia, acknowledged for his expertise in quality outcomes for pancreatic cancer, and Dr. Matthew Katz, a rising star in pancreatic surgery, who will advocate for a neoadjuvant approach. And Matt's published extensively recently on more than just the clinical advantages, but the economic and physiologic advantages of such approach. So it should be fun. My discussant, our fellow moderator, is Dr. Jason Fleming from the MD Anderson Cancer Center. And to kind of set the table before we actually cook the meal this afternoon, Jason's going to give us a little bit of a background on the definitions of borderline pancreatic cancer. Gentlemen, have fun.
Thanks, Mark. So if you're not somebody that I know this group thinks about this, but not everybody does this a lot. So I just wanted to kind of show some data slides that give us some of the definitions that are out there, so that you have these in your mind, and also some of the direction that this has gone. So these CT scans kind of show the spectrum of, from an imaging standpoint, what most of us have come to include in the three categories of localized pancreatic cancer, which would be a potentially resectable patient on the left, a locally advanced case on the right, and a borderline in the middle. And I just wanted to kind of unpack those definitions a little bit. So if you start with the AJCC staging, this was reorganized with the help of many in this room several years back to reflect some of these clinical questions, which essentially mirrors the fact that surgical resection really offers you the best and only chance for cure. So this staging system is meant to reflect that, in that a T2 versus a T3 tumor is one that extends, that is confined or extends beyond the pancreas, and a T4 would be a locally advanced or unresectable case. But as we all know, it gets a little more dicey about, what blood vessels are you talking about? What do you mean by borderline? And so the NCCN has, again, with members of this group involved, have tried to weigh in on this in order to provide some clarity, because there's many non-surgeons involved in seeing these patients, and how do they interpret this? Radiologists are involved. So this is the definitions that they came up with in their consensus meeting, which is a resectable is a tumor that would have no SMV abutment, distortion or clot, and a clear fat plane around the celiac, hepatic artery, and SMA. A borderline, they would say, would be SMV abutment, short segment venous occlusion, encasement of the gastroduodenal artery, no celiac abutment or SMA abutment of less than 180 degrees. And then a locally advanced would be SMA encasement of greater than 180, celiac abutment, unreconstructable SMV disease, and nodes outside the field. But, you know, even as and this resectable is reflected in that AJCC stage 1 and 2 patient. But, you know, what happens is in reality we start tossing these terms around, and do you mean resectable, all are resectable? In other words, if you see a CT scan and you think it's resectable, that means that patient should go to the operating room without stopping at all? Or do you mean localized? Localized could mean 3 different categories. And so in our lexicon of how we take care of patients, it can get confusing. And that sometimes can be a limitation of use of these terms and make it difficult to understand what we mean. And so anatomic staging is really driven around, staging is all driven around anatomy and the anatomy of tumor resectability. But as everyone in this room who sees these patients knows, you may see a patient who has a resectable tumor by the image, but that patient is not someone you would ever want to operate on, which enters into kind of how this borderline has evolved in some circles from anatomy only to patient. And that's an area that's evolving. We have some retrospective data from our own institution that really has led us to, in our practice, divide patients really and use these 3 categories. The anatomy as only being one, and then borderline B being a patient who you think may have metastatic disease, like a high CA19-9. So an A patient would be that patient who has a borderline tumor, but all other systems are go. That's a patient who you would operate on. And the B patient would be also a patient who looks pretty good, maybe ECOG of 0 or 1, but they've got a CA19-9 that's greater than 1,000, even though you can't see anything on CT scan, some lymph nodes that look suspicious and are maybe along the aorta and outside your field, but you don't have a diagnosis of metastatic pancreas cancer. And then the C's are they have poor PS, octogenarians. Maybe they have a comorbidity that you could reverse, like ischemic cardiac disease that a stent would correct, or a valve that a new valve would correct. And so so Matt published, this is what Mark was referencing, Matt published this in 2007, and it's kind of evolved into a way that we see patients, which is really reverse order of that ABC, meaning that if a patient comes into our clinic and they're not somebody who you would ever do surgery on, they've got a wheelchair and oxygen and they're on dialysis, you don't need to go through the rest because the CT scan is not going to help you. So that's kind of this evolution. With that, I'm gonna be quiet and show you the first case. So what these guys are going to discuss is the use of upfront surgery versus preoperative therapy in this case. So we have a 59-year-old who's got a performance status of 0, meaning they're fully functional, they have no pending medical issues, their CA19-9 is less than 10, and they have this mass, which showing you some representative cuts. They've got greater than 180-degree involvement of the superior mesenteric vein with some compression that you can, let's see if I can make this, that you can see some beaking here, maybe a little thrombus here, and the CT scan is otherwise without evidence of metastatic disease. So with that, we need to upload Dr. Vollmer's slides, and he's going to present first.
Okay, thank you very much for the privilege of speaking here today. So this isn't going to be so much a debate when they talk to us as much as a position statement, but there's going to be some contention, no doubt, because our positions are different. But I thought this is, instead of how I do it, this is a how I see it forum today. So as we heard from this morning's discussions, neoadjuvant for pancreatic cancer, it's all the rage. I mean, there was amazing stuff this morning to consider, and very confusing stuff, but it is the hot topic for us now. and we're going all in on it. Let's see what's out there already. There are 2 meta-analyses that show that there is no survival benefit for neoadjuvant for resectable disease. If you move up the ladder towards the borderline resectable, there are single-arm phase 2 studies that show modest benefit for these sorts of tumors. And based on that, the NCCN has, based on a lower level of evidence, category 2B only, that it's consensus that this intervention is appropriate. So I take pause when I see that because it's really not rigorously well defined yet. So the real question is which approach is better, going to surgery first versus going through this arduous process of the neoadjuvant therapy. So here's the data directly comparing the preoperative versus postoperative adjuvant process in a rigorous manner. Don't blink, okay? So there is no randomized controlled trial. There's no phase 3 study that's going to make this, that's going to show you anything at least at this point in time. And it's been difficult to even launch something like this. So while my friend Cy and others are going to bring you a lot of theoretical refreshment on neoadjuvant care, what they cannot do is fill this chart with data at this point to support that. So now that I've won this debate and I've got to fill 5 minutes at this point, I'm going to keep going with some of the position statement kind of stuff. So here's something I think about a lot. Here's your original situation. This is the case that we have today. You decide based on what you see here not to operate for whatever reason. This is, you know, your philosophy. It says, I don't like the way that looks. It's ugly. It's on the vein. It's probably not going to come out. It could be a tough operation, all these kind of things. All right? So here's what you get 6 months later. You get what you get. Matt himself has shown that less than 1% of these pictures are going to change with neoadjuvant therapy over that period of time. So what was it then that you, what is it now that you like that you didn't like then? And why would you go forth with it? Why do you like it now? I'll tell you another thing here. It's a crapshoot. I don't know if that needs a vein resection or not, or how extensive it is. It really is. The imaging does not match up necessarily with real-life resectability when you operate. And this is work from the WashU group that says it's about a 50% chance at predicting whether this is going to be resectable or not from the imaging. So I think that there's a lot of people who are, have this disease who are not being given the benefit of the doubt to get the definitive therapy of surgery for cure. So here's more on vein involvement. This is a very nice study from the Central Surgical Group. This reviewed almost 500 Whipples for cancer, 6 institutions. No neoadjuvant therapy was given. And in that experience, only 14% of the time was a vein resection performed. And with that, whether you got a vein resection or not, there were equivalent R0 resection rates. In their multivariate analysis, vein involvement was not predictive of disease-free or overall survival. And they quote in this paper, these data suggest that upfront surgical resection is an appropriate option. Thanks, Cy. And call into question the inclusion of isolated vein involvement in the definition of borderline resectable disease. So, vein resection, by the way, is dangerous. We have 2 papers that point to this on multi-institutional, larger scale than single institutional studies. One is a current one about the perioperative risks and actually shows that maybe these are even more dangerous in high volume centers. And then a study that I presented here 4 or 5 years ago on causes of mortality in pancreas resection showed that vein resection was a driver of mortality. It's also overused. If you look at reviews or papers, or you see a lot of reviews from around the world on pancreatic cancer outcomes, some with neoadjuvant, some without, vein resection is used an awful lot, probably more than it has to be, and I'll quote 50 to even 75% of cases in some of these series are having vein resections now. What you find here is the actual tumor involvement in these is about a third of the time or less that you're doing it appropriately. Now, there's another point of view about this, and that is that using neoadjuvant therapy, it's like a biological incubator. It's going to allow you to see the progression of the disease, yes or no, where it's going over that period of time. Well, the facts are that you're going to get about a 5% occurrence of early progression after Whipple's for pancreatic cancer within 3 to 6 months. Maybe I'll give you 10% at the most, but it's a very small amount. And these are terrible outcomes for us. We feel terrible when we do all the work of the operation and 6 weeks or 2 months later, the patient's got metastatic disease. It's bad. But how can you rule out early progression of this disease with neoadjuvant therapy when the regimes used are as short as 2 weeks long? All right, so there's a full cornucopia of processes and protocols being used between 2 weeks to 6 months and even longer. So as we heard about a little bit earlier today, one of my solutions for this is laparoscopic staging to help that understand that, where you're going to get about at least a 10% yield, if not 15% even today, by doing that. And these are actually rarely done in most of the neoadjuvant protocols that are presented in the literature. It's surprising. I don't know why. Now, guys, tell me this. This stuff is really confusing. What drugs should I use? If I wanted to do this, what modalities should I use? How hot should they be? How much radiation therapy? How long does it take? I don't know. We're all doing different things out here. And it's coming to an ebb now with so many single-center papers doing their own ma and pa process with this. Another thing I've learned along the way is that patients want clarity when they come to see you. So they're in your office. They've already made the commitment to go to surgery, which is a huge endeavor, right? But how many times have you been asked in your workup this question from them? Doc, I'm not going to need chemo, am I? They fear chemo. It's because they have a better experience with it, but they really don't like it. And worse, so do your medical oncologists, particularly in the age of FOLFIRINOX now. They don't like complications. They don't like treating people in the hospital, and that's where we're going with this kind of stuff. So I think that for a lot of people, they want to know the pace of their disease up front and live with the consequences, good or bad, from that. So it is, but it isn't. The purpose of neoadjuvant is to guarantee the complete delivery of systemic therapy early. That's what I hear so often in these forums. So if that's so, why do so many patients, up to 50%, and at least a third, if not we saw today in the national study, get more therapy after their surgery? You're basically, for some of these people, committing them to chemotherapy for life, all right? And some of our interpretation of the outcomes from this are tainted by the fact that some of these people getting neoadjuvant therapy are getting much more chemotherapy than the people who aren't getting surgery first. So let's go back to some of that today. Now, you could have said that I'm in a bad position here because what I presented earlier is sort of damning. There is seemingly a survival advantage to neoadjuvant therapy on a national scale here. So I was to the point where I was going to concede that this is a good selection process. And if you look at the yellow curve, the reason I say that is you've got a big drop-off there in the first couple of weeks to a month that makes that curve go down. And that probably has to do a lot with death and perioperative complications and such. But I'm not so sure I'm going to concede that, okay? So when I was asked to do this by Mark, he said, I want you to get up there and talk from the position of an experienced pancreatic surgeon. I don't have as much as some in this room, but I've been through a couple of wars with this. And I do have data to tell you about my own personal experience and those of the people I've worked with at 2 different institutions. And you see from that list, there's some pretty good surgeons on that list that know what they're doing. So this was presented a couple years ago at the HPBA, and what we showed is in 424 cancer resections at 2 institutions, 10 years, 80% of these cases were fairly advanced, T3 or T4 cases. That occurred. So here's the outcomes from our practice. Vein resection, in my experience, has been needed very infrequently. It's about 5% of the time. And when we do take the vein out, 2/3 of the time it is involved. So I'd argue that we have a better selection process to when there's actual involvement of the vein than some of the other data out there. The margin positive rate's at 35%, and we had no R2 resections. This is entirely acceptable and normal for pancreatic cancer. The 30-day mortality rate is 0.7. That's 8 times under the data we showed you from the national database today for surgery first. 90-day mortality is 1.7% only. Unresectable disease, so you may say, well, you're taking a lot of people, how many times do you bail out? Okay, well, it's a limited amount, and it's 15%. And even though I will strongly argue that a palliative bypass is a good operation for many of these patients and gives them a good quality of life afterwards. And we were able to show, even in these locally advanced cases, 20-month survival when you pair in advanced radiation therapy with that. We also were able to bring chemotherapy to about 80% of our patients, not the 50% average that's bantered about. And with that, we had very strong outcomes data for national averages at that. So what matters? It's not about the nodes. It's not about the margins, and you're going to hear plenty of that from the people who ensue. But it's about long-term survival. So here we are with the graphs from before. Look at the bottom, where at about 3.5 years, it all comes together. There is a marginal or modest event of a 4 months difference with the neoadjuvant process here. So, if you know anything about Kool-Aid Man, he likes to bust through walls. What I can tell you is that this neoadjuvant process is not going to lift the ceiling of that 5-year survival process. That's how I see it. Thank you.
So now that Chuck tried to confuse you, let's get back to the facts. So I want to thank Dr. Talamonte and Dr. Fleming, as well as the Pancreas Club, for asking me to give this talk. My position today is that patients with borderline resectable pancreatic cancer should receive neoadjuvant therapy, specifically those patients who have greater than 180-degree vein involvement. Recently, we proposed a definition for borderline resectable pancreatic cancer in the context of a clinical study for the intergroup. And utilizing that definition, the patient we're describing today has a tumor vein interface greater than 180 degrees and therefore has borderline resectable pancreatic cancer. And there are many reasons why we should consider neoadjuvant therapy for this group of patients, but I'm going to just go over 4 reasons, and there are many more. So argument number 1 is that a high proportion of patients with borderline resectable pancreatic cancer already have systemic disease, and neoadjuvant therapy can select patients with limited vascular involvement that may benefit from surgery. Now, everyone in this room has seen the slide. These are the studies that have actually given us actual 5-year survivors following pancreaticoduodenectomy, and you can see that ranges from 4 to 27%, and that 27% is actually a neoadjuvant study, so it's a bit higher than the others. So again, suggesting that majority of patients already have systemic disease at diagnosis. This is a landmark paper that was published in Nature where the authors sequenced primary and metastatic tumors, evaluated the clonal relationship among primary and metastatic lesions, and their analysis determined that the timing of genetic evolution determined that it takes 5 to 10 years for metastasis to form. Again, most of these patients have systemic disease when they're diagnosed. The subset of patients with borderline resectable pancreas cancer are probably a more aggressive subtype, and therefore the incidence of systemic disease may in fact be higher. If we look at the studies that have been done with borderline resectable pancreatic cancer, you can see that 33 to 60% of the time patients progress on therapy. This suggests that 30 to 60% of patients will not benefit from a surgery-first approach. Argument number 2 is that borderline resectable pancreatic cancer are at high risk for margin positivity, and in the absence of a preoperative therapy, a positive margin portends worse overall survival. We know that patients who have a positive margin resection have survival rates equivalent to medical management. This ranges anywhere from 8 to 12 months. Now, everyone in this room wants to have a negative margin resection because those who have a negative margin resection have better survival than those who have positive margin resection. If we look at the subset of patients with borderline resectable pancreatic cancer, we can see that the risk of margin positivity is significantly higher if a surgery-first approach is taken. This is a study recently published from the UK where they evaluated 1,500 patients, and you can see for the entire cohort, with a surgery-first approach, the margin positive rate is 54%, and for the subset of patients requiring a vein resection, that margin positive rate was 63%. Again, a surgery-first approach for borderline resectable patients is associated with a positive margin and a worse survival. Argument number 3 is that venous involvement of greater than 180 degrees predicts need for venous resection, unresectability, and worse survival, and therefore patients should receive neoadjuvant therapy. And this is a study from Professor Ishikawa in Japan that was published in 1992. Most of us in this room are aware of this study. The authors of this study try to equate the relationship of the tumor-vein interface with postoperative outcomes. They categorize the tumor-vein interface into 5 categories. For the purpose of this argument, categories 2 or subtypes 2 and 3 represent borderline resectable tumors. And you can see for those patients, Ishikawa types 2 and 3 that have semicircular or beyond semicircular involvement, their survival is worse at 3 years compared to those without vein involvement. So venous involvement of more than 180 degrees was associated with worse survival. A similar study from the UCLA group published by Liu utilized a radiographic staging system where they categorized the tumor-vein interface into a CT definition where grade 0 had a no tumor vein interface, types 1 had less than 1/4, types 2 had 1/4 to 1/2, and grade 3 had between 1/2 to 3/4, and grade 4, 3/4 to circumferential. So again, types 2 to 4 represented those patients who had borderline resectable tumors. And if you look at the little graph on the left, if you look at the resectability versus unresectability, you can see that all patients with grade 0 or 1 were resectable, whereas there was a high rate of unresectability for grades 2, 3, and 4. So venous involvement of more than 180 degrees was associated with unresectability. And then the MD Anderson group published this paper that evaluated the tumor-vein interface as a predictor of intraoperative, pathologic, and oncologic outcomes in borderline resectable patients. They evaluated 254 patients and utilized a CT definition to divide patients into no interface, less than 180 degrees, or greater than 180 degrees, and then established the need for venous resection, histologic invasion, and survival. And what they found was that patients who had more than 180-degree involvement, the rate of the need for venous resection was 89%, and 71% of these patients actually had histologic invasion, despite what Chuck told you earlier. More importantly, the survival for these patients were significantly worse compared to patients who had less than 180-degree involvement. Thus, tumors involving the SMV more than 180 degrees require venous resection, may be unresectable, and have worse survival and should be considered for neoadjuvant therapy. And lastly, in patients with greater than 180-degree venous involvement, neoadjuvant therapy can improve margin negative rates and survival. This is a study from the Fox Chase group with Dr. Hoffman. They utilized the Ishikawa staging system and looked at 109 patients with borderline resectable tumors and compared those undergoing surgery first versus those who had a neoadjuvant approach. And though patients who had a neoadjuvant approach, they had improved survival, higher margin negative rates, as well as higher incidence of node negative resections. This has also been demonstrated by multiple studies where in patients with borderline resectable tumors, a neoadjuvant approach can achieve margin negative rates as high as 94% and as low as 67%, all acceptable numbers for this aggressive subtype of patients. And here's the best of the rest. It's what the experts say. If you look at what the NCCN recommends, if you look at what the HPBA, SSAT, SSO recommends, they recommend consideration of a neoadjuvant approach. It offers us an opportunity to complete the systemic therapy. Radiation may work better preoperatively. It allows us to assess the response and potentially downstage the tumor. and may decrease perioperative outcomes. Thank you.
Well, first of all, I'd like to thank both of these gentlemen for the time and effort it took to put into those slides. We have time for one or two questions. While we wait for any questions to come to any speakers to come to the microphone, let me have a show of hands. That case that was presented, who would take that patient primarily to surgery? Surgery is their first step. Neoadjuvant therapy instead. Okay. Sir, question.
Yes, my name's Ed Purich. My question is, I think, complex, but it's simple. It's that you were talking about metastasis. Well, from many of the sessions that I've at other meetings, it's evident that the progenitor to cancer is circulating and making residence at other places in other tissues, like Pannon's 3s. Well, and this could be up to 8 years before you find some type of visual situation where the pancreas is forming a cancer or tumor. Whatever is the salient event to finally populate the CFTR, the 15 spots, so that it can form cancer, would you call it metastasis if the tissue is already growing somewhere else, just like islet cells grow next to the liver? If they did that before they were cancerous, would that be metastasis? And they were converted by the same salient event that converts it in the pancreas to cancer? So when you're talking about something really happening very quickly, metastasis, are you talking about metastasis or the progenitors becoming cancerous that are at other spots? That's my question.
I think we're talking about evidence of that, right? So the progenitor
The
cell
progenitors
situation is
to-
not visible, it's not recognizable to us at this point.
They spin off, and the immune system's supposed to destroy them. But for some reason, pancreatic tissue doesn't get hit by the immune system quite the same way as other tissues, I guess. Because if it did, I don't know how islet transfer.
Sir, I'm going to interrupt just for a second, only because we have another speaker. Go ahead, Alex.
Alex Rosemurgy. This is debated at many meetings, and why don't we study this? It's getting to a point where I can't stand anymore coming and hearing these debates, which are emotional and never data-driven. And I would suggest the organization maybe sponsor this. Now, because I'm so tired of this, I have taken upon this that I will not die, hope, before I do this. And so I have written a protocol. It's a neoadjuvant therapy, operation adjuvant therapy versus adjuvant therapy trial. If anybody would like to participate in this, I would be very happy to share this with them. The only thing I want to do is I want to answer the question, because I really, truly am emotionally over this. It's like watching two petulant children. No, I don't mean you both, but I mean, just in general terms, two petulant children argue, and one says, oh yeah, and the other one says, oh yeah, and the other one says, oh yeah, and oh yeah, and yeah. We can answer this, and it takes us a couple years. We can answer this, we can be done with this, and we can move on. It's A. Rosemurgy, first initial, last name, at hotmail.com, and I'd happy to have this organization take this over. It's not about me, it's about getting the question answered. And however I can be to facilitate this, I'd like to do that.
Fair enough. I'm going to move on for the sake of time. Let's do the second case, and then we'll do some debate after that or some discussion after that. And if there's even further time left, then we can open up the floor again.
Okay, I'm going to ask Drs. Yo and Katz to come up. I need that slide that we had up, the case 2 slide. Let's see. Nope. Fleming. There's a file. Yeah. So this is our second case, which has a little different components to it. This is an 83-year-old woman who had some cardiac stents placed for ischemic cardiac disease a couple years ago, but currently has ECOG performance status of 0. She's got a CA 19-9 that is within normal limits or less than 40. And on imaging, she has this 1 centimeter tumor in the head of the pancreas. There's no vascular involvement that can be detected on the imaging, and she has no lesions that are suspicious for metastatic disease. Dr. Gibb.
Well, great. Thank you very much, Jason. I want to thank the Pancreas Club for the invitation. I want to thank Mark and Jason for getting me organized here. And it's a real honor to be here and do this. This is, for me, the best meeting of the year. It's a lot of fun to be here. I'm going to try to be a little provocative, so apologize if I upset anyone. But I'm going to be a little provocative. I'm going to have a little fun, and I'm going to, the resolution that I have is let's just operate and take this tumor out because we're surgeons. So let me have my next slide if I could. So I have a couple disclosures. I'm a GI tract surgeon. I work with a large group, a big multidisciplinary group. We've had some funding over the years. We have an extensive referral practice. We work with a lot of pancreatic cancer advocacy groups. Most of our patients, sadly, wish they never had to meet us. But we love to operate on the pancreas. So is this really a coin flip? Is that what we're talking about here? I mean, is this either operate or give the patient upfront neoadjuvant chemo? I think not. I think it's pretty straightforward what to do on this patient. And for this, I have 5 lines of reasoning that I'm going to go over with you one after the other. The first is that surgery is a cure. Chemo's not. And I'll show you some data, some very personal data. Number 2, surgery's safe and underutilized nationally. And I'll show you some embarrassing data from the United States of America that I'm embarrassed to be a part of in the surgical community. Number 3, current chemotherapy is largely ineffective. It's non-targeted, and it's very costly. And we haven't heard anything about the cost of these drugs, so I'll educate a little bit. Number 4, beware, if you discriminate based on age, you could go to jail because you're breaking the Americans for Disability Act. And I don't think many of you want to spend time in federal prison. And number 5, it's important to optimize the surgical experience, and 80-year-olds need a little bit of a different care than do 30-year-olds. So a few years ago, as part of the Jefferson course that we do, the ski course that we do, we had a debate, and the debate was who's most important in the management of patient with pancreatic cancer, and there were 4 debatees: gastroenterology, medical oncology, surgery, and palliative care. And this is a classic raft debate. Who do you want on the raft? And who should be on the raft? Because you can't all fit. And the way I look at it is this comes down to which of these 4 specialties is most crucial to the management of pancreatic cancer. So we can show a lot of data, or we can just look at pictures. I'm sort of a picture guy. Pictures 1,000 words. So let's look at a picture of those patients who've been cured of their pancreas cancer by gastroenterologists, by oncologists, and by palliative medicine specialists. So much like Dr. Vollmer, don't blink because there's nobody there. Nobody there. On the other hand, let's consider some of the patients just in our small microcosm in Center City, Philadelphia, who come back for our annual patient symposium, who've had adenocarcinoma, underwent resection. Some of them had pre-malignant lesions. Some got chemo, some didn't. Some had surgery alone, and some are 15-year survivors. And here's a picture of 60-plus people, 60-plus people, just in our little microcosm. Now, in case you didn't see the dichotomy there, let me repeat this slide for you. So as a review, compare the picture on the left to the picture on the right. Which specialty do you think is most crucial to the management of pancreatic cancer? Number 2, the second issue here is surgery's safe in America, but it's vastly underutilized. So take the NSQIP calculator. I played with this. Now, this is only for patients. I'm sure most of you have done this. You've put the data in. On the top here, this is 48153, pancreatic oduodenectomy, and I took the patient age 75 to 84. I made it a male, oops, but and then totally dependent functional status, emergency surgery, ASA 5, chronic steroids, SIRS, diabetes, cardiac history, dyspnea on exertion, still smoking, COPD, and obese. Well, anybody going to operate on this patient? I don't think so. But this would predict a death risk of 62% and a hospital length of stay of 27.5 days. I think you'd be lucky to get this patient out of the hospital. But realistically, let's take a healthy ECOG 0 gal, male, it doesn't matter, male or female, and the rate of death is less than 1%. The rate of serious complications is less than 20%. And the predicted length of hospital stay, 7 days. So not bad. Surgery's pretty safe. And if you look at certain high-volume centers, we at Jefferson are a low outlier in NSQIP, and this compares 4 outcomes: mortality, morbidity, readmission, and return to the OR to the NSQIP data, and shows that we're actually superior in all 4 of those categories. So no question that in certain institutions who are NSQIP outliers, you can actually do better than NSQIP. So surgery is certainly safe. The embarrassing thing that Carl Billamoria published 7 years ago now is that we're not doing a very good job of getting people to the OR, particularly for stage 1 cancers. Here's almost 10,000 patients, stage 1 tumors, like the patient we're discussing today, and only 29% underwent surgery, of which essentially all of them were resected. But the contrast to that is 71% did not undergo surgery, and in 38% they were never offered surgery. I say shame on America. These patients should have been operated on. The only legitimate reason, I think, in this group to not have surgery is if you refuse. I'm sure some of the ones that were discounted because of comorbidities were falsely stratified. And if you think these data are old, Jeff Hardiker and his group from Cleveland just last year at the SSAT presented trends in the treatment of resectable pancreatic cancer, and in the data, stage 1 tumors again, even at teaching hospitals, the resection rate is only 50% and really hasn't changed from 03 to 10. And in community hospitals, it's only 30%. Shame on America. Now, third issue, current chemo is largely ineffective, it's non-targeted, and it's incredibly costly. We're victims of false advertising, people. This is New England Journal, October 13, when there's this article, which many people are familiar with, increased survival in pancreatic cancer with the Abraxane. Right, big article. Dan Van Hoff, great job. This is the survival curve. This is GEM compared to GEM plus Abraxane alone. You can see the survival curve is better with the doublet. The hazard ratio is 0.72. The p-value is 0.001. So there is a significant survival advantage in metastatic pancreatic cancer comparing GEM plus Abraxane to GEM alone. As I'll show you soon, this is a flawed study. This study didn't have appropriate scientific rigor. The control group is wrong. The control group should not have been GEM. The control group should have been GEM plus paclitaxel. The company wants to sell drug, and you all have been duped. You've also been duped by the advertisement that Celgene puts out. This advertising says ignite survival in first-line metastatic pancreatic cancer. And it shows these people holding candles. Somehow the spirits of the gods are back with us. We're igniting survival. And here are the data. It's the same data. And these are all correct, except they've lied about the p-value. Now the p-value magically has 3 zeros in it. And it's now P0001. I think it's a dual false advertising. This is not a home run drug. This is not a single. This is not a bunt single. This is a foul tip. Your results with these new medicines are certainly exciting, says Walter Porres in surgery. In surgery, however, we consider such results failures. Now, the other thing I thought of was, what does this cost? So here's some dirty data from Jefferson. So an uncomplicated Whipple at my hospital with a 6 to 7 day length of stay, the pro-fee receipts, let's just look at receipts. The receipts, $6,000 total for pro-fee services, $3,700 to surgery, about half that to anesthesia, half that again to pathology. The hospital gets 33. You can see the receipts are about 40K. 40K. How about charges for neoadjuvant chemo, uncomplicated patient, 5 to 6 monthly cycles, 5 or 6 monthly cycles, professional services 800, hospital services 141 plus thousand, 143,000 total services. We bundle our charges. We have a hospital-based infusion, and they get huge reimbursement breaks. So just in case you miss those data, I'll summarize it here for you. Whipple procedure, receipts 40,000. Neoadjuvant chemo, no surgery in here yet, folks. Just neoadjuvant chemo, 143,000. How many of these people are going to be cured without an operation? I showed you the picture. So the other important thing is there really aren't great data on cost effectiveness. This is the best I could find, Current Oncology last year, and it looks at systemic therapies for metastatic pancreatic cancer, and then we can infer to neoadjuvant. Let me take you through this very important study. Markov modeling used utilities to designate stage 3 or 4 toxicities from chemotherapy and looked at outcomes based upon past studies. 4 groups. This is pre-GEM plus Abraxane, the false advertising study. GEM alone versus GEM plus capecitabine versus GEM plus erlotinib versus FOLFIRINOX. Life expectancy appropriately increases from left to right. Quality-adjusted life years increases, but the incremental cost-effectiveness ratio compared to GEM alone balloons up. Now, true, these are Canadian dollars, but make no mistake about it, these data summarize the cost administering only 1 month of each regimen. 1 month of each regimen. So, this is the first study that ever looked at cost effectiveness. Of course, it's pre-GEM and Abraxane. The incremental cost effectiveness ratios increased, and they're relatively high compared to GEM alone. And FOLFIRINOX, which I think many might consider sort of the premier neoadjuvant therapy at this point, pretty expensive. And what is the society's willingness to pay threshold? What are we willing to pay in order to deliver this chemotherapy prior to curative surgery? And I would remind you that the World Health Organization says it's 3 times the gross domestic product per capita. So in Canada, FOLFIRINOX actually falls right on the edge of whether Canadians are willing to pay for it or not. A couple weeks ago in the New England Journal, great article, Comparative Effectiveness Questions in Oncology. Please wake up for these next 2 slides. This is really critical. The high cost of these new cancer drugs has been criticized by many, and it's been lamented in the press. Often there's only minor improvements in survival, and they don't appear commensurate with the prices. These expensive cancer drugs cost society in 2 ways. Number 1, they're big prices, have to be borne by the payers. But number 2, these prices preclude independent comparative effectiveness research. Great example. Look what's on the top line of this in the New England Journal just a few weeks ago. Estimated sample sizes and costs to prove clinical non-inferiority comparing biosimilar cancer drugs. Metastatic pancreas cancer, the next generation drug is Abraxane. The parent drug is paclitaxel. It would take 1,000 patients per arm and $37 million drug costs to do this study, to do it correctly. So the preceding table shows that the purchase price of these drugs is really astronomical. And each of the trials that I showed previously here, and there's trials in renal cell, metastatic breast, et cetera, each of these has problems in that the newer drug gained FDA approval compared against placebo or standard drug, GEM alone, but not against the parent drug. The benefit of the new agent was marginal. Some trial evidence in other cancers suggests paclitaxel and Abraxane are equivalent. A demonstration of equivalent efficacy would mean substantial cost savings to society, and the purchase price of these new drugs really makes the cost of doing the trial impossible. So our obligatory financial stewardship, just last week, New England Journal, we as docs have to pay attention to this. Healthcare costs are strained. The American Board of Internal Medicine Foundation has the Choosing Wisely campaign. The CDC has antibiotic stewardships. It's time for us in the oncology and surgical community to pay attention to this. And I think the bottom line here is if we as physicians shirk our responsibilities to act as financial stewards, then we're actually doing harm and deleterious effects on the community as a whole, on the healthcare community as a whole. So we need to wake up to the fact that these cost issues are very important. My fourth, do not discriminate based upon age is very simple. We've published several studies in the past. Should Whipples be done in octogenarians? Yes, yes, they should. Matter of fact, I saw a patient a few years ago who was 89 and 11 months old, and I showed him these data. And we had a 4% mortality rate if you're an octogenarian. We had a 0% mortality rate in 10 patients who were in their 90s, and the guy said, I want to wait a month to have my operation because I want to be in the 0% group. Also, here's 1,000 pancreatectomies in our database at Jefferson, 1,000 pancreatectomies by age of the patient. And here's 12% of our patients are in their 80s. So if you're willing to essentially ignore 1 out of 8 patients that come to you and you don't like to operate, then don't operate on octogenarians. My last point is it's important to optimize the surgical experience. And I'll make 3 points here. This patient, this 83-year-old gal today had cardiac stents. Please don't stop her aspirin pre-op. When you send this patient to the pre-op testing area, or when the local cardiologist says to stop the aspirin, go bite him in the foot and show him the data that says you shouldn't stop aspirin preoperatively because of the aspirin withdrawal syndrome and the increased risks of cardiovascular side effects. And in fact, we just published in Surgery just a few months ago our experience with over 1,000 patients saying that aspirin therapy was not associated with increased risk of bleeding or transfusion post-pancreatectomy. So continue the aspirin, please. Number 2, intraoperative fluid management is very important. Dr. Lavu tomorrow will present this work that was done at the American Surgical, presented at the American Surgical last month. The trial looking at hypertonic saline versus lactated ringers. And I don't want to show many slides from his work, but we clearly showed in this trial that he was the first author on that the use of hypertonic saline in a restricted fluid approach decremented the complication rate by 25% and decremented the total number of complications by 31%. So look at that article. Lastly, it's important how you get patients to recovery. A few years ago, we showed data here that Teresa Yo, my wife, presented, prospective randomized trials showing that an exercise program postoperatively improves fatigue and the ability of folks to exercise and health-related quality of life. And so these are our discharge instructions on a laminated poster, if you will, to go on their refrigerators at home. And you can see exercise program is built in to the discharge summary. So I think my first point's probably the most dramatic. 0, 60 plus. 5 lines of reasoning. I won't review them all with you. Surgery's a potential cure. Surgery's safe. Current chemo, not great. Don't discriminate based on age. Optimize the surgical experience. So I'd say let's operate. And listen, if you guys don't want to operate, 1-800-JEFF-NOW is our line. We're happy to operate. Thank you very much.
Thanks very much. Okay. So could we rush this patient to the OR? Sure we could. Innumerable case anecdotes and small series like the one that Charlie just showed show that pancreatectomy in very well-selected elders is completely feasible. But these studies have big limitations. They're typically small surgical series from specialized centers, and they don't show us the denominator. So how many patients, Charlie, did you see that were over age 80 that you didn't operate on? The surgical results reported in these studies may not be those that can be expected for the large majority of elders with pancreas cancer. In fact, if you look at population-based studies, we know that we're not delivering potentially curative therapy to most elders. Among patients 70 to 84, about 3/4 of patients are actually evaluated by a surgeon, but only 17 to 34% actually undergo surgery. If immediate surgery is the answer, why are we not doing it? Even though elders could otherwise, we're not using this technique, even though elders could otherwise expect to live 6 to 16 additional years if they were not otherwise afflicted by pancreas cancer. So why aren't we doing it? It's because patients are physiologically impaired. This is a study that looked at clinical deficits that were observed in patients greater than 65 years old, and what you can see is that patients greater than 65 have a significant incidence of limitations in their ADLs, limitations in their instrumental ADLs, that is, their ability to cook or clean or other basic functions of life. They have a high rate of geriatric syndromes, high rates of vulnerability, and high rates of frailty. This is geriatric literature. This is not surgical literature. So the results of surgery would be expected to be suboptimal for many of the 70 and certainly many of the 80-plus-year-olds that we supposedly can rush to the operating room. Let me give you I'm down to 3 facts, actually. I condensed them into 3 facts because I thought this was a 6-minute talk. Elderly patients, fact number one, elderly patients can undergo pancreatectomy, but both postoperative morbidity and postoperative mortality are quite common. This is data from NISQIP, 2005 to 2010, which looked at elderly patients who underwent pancreatic duodenectomy, categorized into 2 groups, patients less than age 80, patients greater than age 80. Patients greater than age 80 had higher rates of intraoperative transfusion, higher rates of return to the OR, higher rates of cardiac arrest, higher rates of unplanned intubation, higher rates of ventilator dependence, higher rates of stroke, higher rates of septic shock, higher rates of UTI, higher rates of disruption of their wounds, and higher rates of death. This is Taylor's data. Patients in the 70 to 79-year-old age group had a 1.8 times the risk of dying in the hospital than patients less than 60. Patients greater than 80 had a 4.5 times risk of dying in the hospital than patients less than 60. Fact number 2, elderly patients are at high risk for loss of independence, at least temporarily, following pancreatic surgery. Again, this is Taylor's data. Patients aged 70 to 79, only 50% of them are discharged independently. The remainder require some sort of caregiver or even long-term care as an inpatient. Patients greater than 80, only 1/3 of patients are discharged independently. The remainder discharged to home health at home, or 40% discharged to a long-term facility. Fact number 3, elderly patients that are resected are at extraordinarily high risk for not receiving necessary postoperative therapy. United States data from SEER 1992 to 2002, 1,300 patients, only 49% of the entire group received adjuvant therapy. Patients greater than age 75 were half as likely to receive it. Data from Australia, again, this is data from 12 hospitals. 439 resected patients, 47% received adjuvant therapy. Greater than 70 years old were significantly less likely to receive adjuvant therapy. Only 30% of patients greater than 70 received adjuvant therapy in that study. So this current strategy, super selection of a relative few for immediately potentially curative surgery and acceptance of suboptimal results, ain't working. So what is a possible alternative? Neoadjuvant therapy. Give them their chemotherapy and or chemoradiation therapy up front. There's several potential advantages to this approach. Number 1, it allows better selection for surgery on the basis of physiology and tumor biology. Number 2, it provides a time interval within which physiology and comorbidities can be evaluated and optimized. Imagine doing that
walking program in the preoperative period instead of the postoperative period. And it guarantees that every elder who undergoes pancreatectomy receives multimodality therapy. So I don't have a lot of data to prove that this strategy is better, but I will give you our experience, just like Chuck did. This data was compiled by one of our graduating fellows, Amanda Cooper. Over an eight-year period at Anderson, 236 patients aged greater than 70 with resectable or borderline resectable tumors. That's everyone who presented greater than age 70 with anatomically borderline or potentially resectable cancer. 24% of those patients were treated palliatively. The remainder were treated curatively, or what we would consider curative treatment. 15% of those treated curatively were resected. Only 42% of those patients at Anderson received postoperative therapy. 85% received preoperative therapy, among whom 48% were resected and 52% were not. Among patients resected, 2% perioperative mortality, 91% discharged home independently, 85% of patients who were resected received all components of multimodality therapy. I know, Volmer, you don't want to hear it, but that's what it is. Resection following neoadjuvant therapy is more favorable. So if you undergo surgery, you should probably enjoy its benefits. In this series, patients who received neoadjuvant therapy and then underwent surgery had a significantly longer survival than patients who underwent surgery first. But even more remarkable, and I'll leave this slide up, patients who underwent primary resection had a median overall survival that was no better than that of the entire group of patients who initiated neoadjuvant therapy, whether or not they were ultimately resected. So to conclude, elders who undergo de novo pancreatectomy are at high risk for perioperative morbidity, mortality, loss of independence, failure to complete necessary adjuvant therapy. Neoadjuvant therapy may help select elders who are better able to tolerate and benefit from surgery, reduce the risk-benefit ratio associated with Whipple and pancreatectomy, and maximize the receipt of multimodality therapy. So I'd argue that this would be a reasonable approach for the patient that was presented. Thanks.
So again, I'd like to thank both speakers for the amount of work and excellent presentations. We are crunching a little bit on time, Dr. Traverso. Time's up. Let me have one last raise of hands for people that would have treated that patient that was presented today with primary surgical therapy. Preoperative chemotherapy. So in the elder patient, there's a vote for neoadjuvant therapy. In the younger patient with borderline resectable disease, we're flipped around. Primary surgical therapy for the elderly patient, primary neoadjuvant therapy for the younger patient with vein involvement. Fabulous work, fellas. I hope you enjoyed this session. Thank you, everyone.
Thanks so much for doing it. That was great.
Sorry we didn't leave enough.
No.